So, the next speaker will be Holly Silvers Granelli, and I'm very happy that she is here. She is from Santa Monica in LA, but she's now in Zurich. That's very good for the technical side of the situation. She is an expert about ACL injuries. She's physiotherapist and research and makes a lot of research, and she has also made a lot in the prevention, and she will speak about
Thank you.
the experience. Thank you very much.
Thank you so much, and thank you for having me. It's a pleasure to be in Zurich. Today we'll talk about ACL injury prevention in women. We'll touch a little bit on men as well, but we've been working in this space for over 20 years, and unfortunately it's still a bit of a conundrum, and we still need to do further work. My disclosures, I'm a research consultant with Major League Soccer as well as the National Football League in the United States, but none of that impacts the discussion today. So we know soccer is the most widely played sport. Globally, there are 300 million registered players in the United States, and since Mario and I have known each other for the better part of 15 years now, this sport has grown. It's currently the second most popular sport in the United States, and it's the first most popular in women. So we have about 25 million participants, over 1.7 million female players. And what's really exciting when we look at the female collegiate game, so those are athletes between the ages of 18 to 25, it's the #1 played sport. The first game was played in 1977, and since that time we've had over 1,200% growth of the game, which is phenomenal. A recent report by UEFA was really exciting to look like it as well. There was between the years of 2013 and 2017, there was 7.5% growth in female player registrations, 11% increase in female coaches, and over 70% increase in female match officials, including those that are officiating male games, which is really exciting. And pay equity is improving for some teams. So Brazil and the FA have recently commanded that pay equity will be an important part of their programs, that the female and male players will be paid equitably. Unfortunately, not for others, and unfortunately including my country, but that's a little bit of a bone of contention, which is in our legal system right now. But there was a report with the Welsh team that they have a hard time even fully funding their senior team. So this is an issue when we think about medical resources as well. If they're not getting paid effectively, are the medical resources an issue as well? And often they are. But when we get back to the injury conversation, we know injuries continue to occur, and in some cases they increase. Soccer injuries we know are not uncommon, and how can we mitigate, particularly how do we mitigate ACL injury risk? So if we look at data from the United States, and this is the high school age group, so these are athletes between the ages of 13 and 18. Right now in the United States, ACL injuries, or girls soccer leads the charge in injury. Boys soccer is listed as #3, just between American football, American football and lacrosse. In the United States, there are about 190,000 injuries in soccer annually, 43,000 of which are ACL injury related. So that's astounding. And that's just, again, this is the young age group, 13 to 18. When we look at the NCAA, so this is our collegiate system, again, these are 18 to 25-year-old individuals. When we look at the differential between men and women, there's about a 3-fold differential, depending on how we look at it from match and or training. But the injury rate for women is about 0.31 per 1,000 athletic exposure compared to their male counterpart, which is 0.13. And unfortunately, when we look at these players longitudinally, just like into their later 20s, 65% of them are no longer playing soccer when they've incurred an ACL during their collegiate career. And this is kind of shocking. 1 in 19 female college soccer players will tear her ACL. So when we look at a standard collegiate roster, which is anywhere between 25 and 30 players, we're looking at over 1 individual, probably about 2 ACLs per season per year. And we can't normalize this. This can't become the norm. We have to do better than this, and I think we can do better than this. There was a nice systematic review published looking at 22 studies in women's football, and the average injury rate in general was 6.1 injuries per 1,000 hours of exposure. But when we look at the huge differential between competition and training, so in competition, that level escalates highly to 19.2 injuries compared to 3.5 injuries in training. And if you looked at the top 5 world ranking leagues that they analyzed, the injury rate was higher compared to those of lower competitive leagues. So this could speak to level of play, and is that an inherent risk factor? This paper was published in the Irish Women's National League recently, and what's interesting, ACL injuries, when you look at them in general, don't lead the charge. When I broke down their data graphically, you look to the right side of the screen and you can see ACL injuries aren't even in the top percentages for all of the injuries listed. However, they did have 8 ACL injuries over the course of 2 seasons. And those 8 injuries alone accounted for 28% of the time loss of every injury that was measured, which is really significant. Their recommendation that clubs should be implementing injury risk mitigation strategies with a particular focus on injuries with high injury burden, such as ACL injury, and I could not agree more. So another study done in collegiate ACL injury, and this was done at the University of North Carolina. This particular university is a soccer powerhouse. They are perennial champions in our collegiate league. So this was of a particular interest to me when they published this study, looking at how many athletes had gone into their program with ACLs already. So again, how many athletes going into the program at about 18 years of age? So 35 of them had already had a reconstruction. Those athletes that had been torn earlier on in their adolescence, 17% of them re-injured and 20% re-injured or injured to the contralateral side. Then 54 athletes tore while they were at the university, and 1.9% re-injured the ipsilateral while they were there. So remember, this is only a 4-year interval, and then 11% injured the contralateral side. Can we do better? So let's look at, of course, we want to always investigate the injury mitigation intervention. So UCLA, which is University of California in Los Angeles, and I'm unfortunately working a little too much with them as of late. They published a nice study. This is looking at all sports, so not specific to soccer. They had identified over 1,100 athletes that had come in with a knee history. 186 of them had had a prior knee surgery, and then 261 of them injured while they were at the university. So athletes with a history of pre-collegiate surgery, so those that came into the university, were nearly 2 times more likely to undergo ipsilateral knee surgery while they were there for approximately 4 years. And remember, these are young individuals, and if we think about the impact of early injury to the articular cartilage with respect to osteoarthritis very early on in their 2nd and 3rd decade, this is a massive issue that we need to address. So this is the UCLA women's soccer team. They're currently ranked 3rd in the nation. They are, again, one of the perennial favorites, and at any given time, 20 to 30% of them have participated with our youth or senior women's national team. I just want to go over 3 particular photographs, and if you would, please do not share these on Twitter. I have permission to share this data, but it's not something we want to publicize as of right now. In 2018, this is the 2018 roster, so those individuals encircled in yellow tore their ACL while they were at the university, so in 1 year. 6 ACLs that particular season. 2 of them encircled in blue came into the program with a history. So 20% ACL injury, which is astounding, and 6.7% of them came in with an ACL injury. Let's look at the next year, 2019, 5 additional injuries. 15% of the team tore their ACL that particular season. 4 had a history. Let's look at the following season. This is the COVID season, 2020, 2021. 7 additional ACL injuries this season. 3 with a history. So this, I mean, I struggle with the fact that we are okay with this. This is an astounding number of ACL injuries on one particular team with knowing that this team is actually a very highly successful team, a highly respected team, most of which are involved with our U.S. National team, either at the youth or senior level. This one particular individual, Cassidy Shimbalanga, who unfortunately has become a dear friend because we've spent so much time together, but she unfortunately has sustained 4 ACL injuries while she has been at UCLA. So as a forward, she was with our youth national team, scored 21 goals in her last competitive season of healthy play. She tore her right side in January of 2017, her left in April of 2019, sustained, unfortunately, a secondary injury to the left in October of 2020 and a tertiary tear. Unfortunately, she's medically retired right now at the age of 20. And future career aspirations, she wants to be in sports medicine, which we absolutely welcome her too, but it's just unfortunate. And we can't help but think from an articular cartilage perspective, what this young woman's going to endure in the next 10 years. We need to do better for her and many others like her. So if we look at risk of secondary injury, like Cassidy, who unfortunately has sustained 4, we know that females are at higher risk. So this paper was published by Mark Paterno looking at the risk factors associated with re-injury, and those happen to be anyone under the age of 19, anyone who's female, and then the triple hop, which, these qualitative assessments have gotten a little controversial as of late, but I think they're an important metric to look at. If you see a difference, in this particular study, when they did the regression analysis, the triple hop for distance came up as a primary risk factor, as well as triple hop for distance from a limb symmetry index perspective. Kate Webster published another paper looking at the exploring high re-injury rates in younger athletes, and found that 47% of these young athletes had retorn within 1 year and 74% within the first 2 years. Now, in her paper, she found that young males were under the age of 18 were at higher risk, in contrast to what Paterno found, that it was under females under the age of 19. But again, these graft re-rupture rates of 28%, this is astounding. Contralateral ACL injuries occurred in 17.7%, and that was approximately 4 years after surgery. So it's not even the uninvolved or contralateral limb is not safe either. So is this indicative of a surgical failure? Is this an indictment more on our end, on the physical therapy side? Are we not serving these people well? What are we missing here? This other paper looking at secondary injury in Swedish football, they looked at athletes between the ages of 16 to 25, and they followed up for about 6.5 years. So it was a nice longitudinal study. And so they broke this down into 3 categories: athletes that returned to play, athletes that did not return to play by choice, and then compared them to healthy controls. 42% of those athletes who returned to play sustained a re-rupture, 18% to the contralateral side. Of those that did not return to play, 19% sustained a re-rupture. So these are athletes that did not go back to competitive sport. These were athletes that were just playing recreationally, perhaps maybe some recreational skiing or cycling, running. So again, that's an astounding number, almost half of what the return to play sustained. And the healthy controls were at about 11%. So again, we're still in the population seeing very high numbers of ACL injuries. 2-fold higher ACL risk for the return to play versus non-return to play, and 4-fold higher risk compared to control. So 2/3 of female soccer players with an ACL reconstruction who've returned to soccer sustained a new injury within 5 to 10 years, 42% of which was a new ACL injury. It's just a very unfortunate statistic, to be quite frank. So when we look historically, back in 1999 and 2005, we had established these Hunt Valley conferences to look at the categorical risk factors associated with ACL. And nearly 20 years ago, we categorized it by 4: anatomy, biomechanics, environment, and hormones. In our particular group in Santa Monica, we spent most of our time on the biomechanical side. Now, 20 years later, we've expanded these categorical risk factors to include genetics, We know there is a genetic component to ACL injury. We see it in families, and we see it in children of parents who have sustained ACL injury. And also expanding to look at the medical training resources, particularly in the female cohort, because we know, as we described earlier in this talk, that the training and the resources available on the female side of the sport are limited, can be limited. Many countries are doing a wonderful job from a pay equity perspective, but the medical resources available to many teams are limited compared to the male side. So we look at one categorical risk factor, and I think Jane did a really nice job earlier today looking at how hormones affect ACL injury rates. Just a quick recap, there are 3 phases: follicular, ovulatory, and luteal. There has been early evidence suggested by James Slaughterback and Ed Voides and many other groups looking at the link between ovulation and the luteal phase and ACL injury, and that's been mainly linked to an increase in laxity, and that's because of elevated levels of estradiol, which affects fibroblasts and collagen synthesis. It also has been shown to increase relaxin hormone, and those athletes that had levels over 6.0 picograms per milliliter had sustained ACL injury risk. The problem is, what do we do with this? There's a controversial recommendation that perhaps hormonal contraceptives may may have a preventative benefit, but I think that's a difficult conversation to have, particularly when we're talking to the youth, athletes between the ages of 12, 13, and 14 years of age. Is that something we recommend medically from an ethical perspective? Puberty and how does puberty impact biomechanics? This is a nice new study published recently looking at prepubescent and early, mid, and late pubescent athletes, and to see what differentials are happening from a biomechanics perspective. And they look specifically at a landing task. We know in general, untrained, and that's an important stipulation here, untrained females land and cut with decreased knee and hip flexion. So they tend to land, run, cut, and pivot with more erect, so less hip and knee flexion. And we know that hip and knee flexion is a very protective element biomechanically for ACL injury mitigation. We didn't see a significant change in muscle strength from pre versus post-pubescence, but when they broke down the biomechanics from the transverse and sagittal plane, interestingly, they did not see frontal plane changes in biomechanics, which is one of the hallmarks of what we think in terms of genu valgus when we identify high risk. They did not tend to see this from a landing, but I think it was task specific here. But they did see significant changes in transverse and sagittal plane with age. So those athletes went through puberty, were indicative of increased force to the ACL, and this was correlated to increase with age, and this correlated to their ACL injury risk. So can we mitigate this risk with training? These were untrained individuals. This was an observational study, and these were untrained individuals, which is, I think these are all important considerations, because I don't think we accept this. We can intervene here. There were 3 video analysis studies. Now, this first study I was part of, we looked at both men and women. The next 2 studies were just in men, Marcus Walden and Francesco Della Via. And what's interesting, though, we found basically the same thing across the board. Most ACL injuries happen in an unanticipated situation. So in a defensive nature, not a defender per se, but in defensive nature. And they tend to be upright. You're trying to anticipate a maneuver. And just like we said in the last slide, hip and knee flexion are protective of the ACL. When we get better activation of the hamstring and the posterior chain, we know that we can decrease anterior translation of the tibia. So that is an important component to all of these video analysis studies have shown the same thing, basically, that they were up, erect, hip and knee extended positions, generally with hip abduction and knee valgus. This is an athlete, Ali Krieger, who is one of our right backs for the senior women's national team. She also plays in Orlando. This was an ACL injury that happened to her. We're going to show here, she's back on the back of the screen. She's going to strike the ball. You have this incoming defender that's coming in. From that particular view, it's hard to say. There is no contact that's being made, but Ali is trying to anticipate the force coming in. I'm going to show that one more time. So you see this high press from this athlete, number 13 in blue, and as she goes to clear the ball, Allie is trying to avoid her, and you see her come in with significant hip adduction, and she's off balance with significant trunk flexion. So let's break the video down. We're gonna go left to right on the screen. So here, Allie's preparing. So actually, from a biomechanical perspective, very normal looking biomechanics here. She's using her arms to offset her center of mass differential. She's in hip extension, abduction, and her knee is flexed on the kicking, both kicking and the stand side. As the shot is taken, we see some perturbation here. So she's got increased, probably a little bit of excessive trunk flexion here. Hip is flexed, knee is extending as the shot's taken. Here the defender, the high press is encroaching. So Allie's trying to react. She's defensively reacting to the press. So she has increased trunk flexion and this lateral trunk sway and significant hip adduction. Now, when she brings her leg to, or her foot to the plant, to the grass, and as the defender is acquiescing, her trunk flexion is increasing and she's trying to avoid the contact. And then as she plants her foot, you can see in the last slide under the purple screen reaction, significant knee valgus. No contact is made. Difficult to see from that particular view, but there was no contact made. The encroaching defender was about half a meter in front of her. Unfortunately, she sustained an ACL injury as well as a grade 2 MCL and an osteochondral defect. So we know ACL injury programs have been vetted scientifically for the past 22 years, to be honest. Work that I've done with Mario and many other groups across the globe, these programs have been scientifically vetted for, there are hundreds and hundreds of studies showing the benefit of injury prevention or injury mitigation programs, and anywhere from a 60 to an 85% injury mitigation benefit. However, compliance and adherence is always the issue for us. Two programs that I was a part of developing. One was the PEP program. We developed, it was an on-the-field dynamic warm-up developed back in 2000, and we had 2 years to this specific study. This was done in high-level club soccer players in the United States and California. We had an 88% reduction in non-contact ACL injury in the first year, followed by 74% reduction in the second year. We brought this program to the NCAA, so those, again, the athletes between the ages of 18 to 25, these were female athletes, and we basically had the same statistics that we saw in the younger cohort. If you look at the bottom of the screen and we stratified the data for practice and games, we had an overall reduction of 72% of non-contact ACL injuries and 100% reduction in practice, which is fascinating. So we worked, Mario and a group of us out of Oslo back in 2005, helped to develop the 11 Plus program. Many of you are familiar with this. I'm not going to beleaguer the point, but I just wanted to show you statistically, because many programs didn't look at how specific this was to injury reduction on the ACL side. The FIFA 11 Plus program, just to remind you, was designed to address all soccer-related injuries. So when we did the study in the United States looking at men, we wanted to delineate whether or not it was successful for ACL injury mitigation. But the first study done in the 11 Plus was done in Norway in female soccer players, nearly 1,900 females. There was a 32% reduction in all soccer-related injury and a 53% reduction in overuse injury, 45% reduction in severe injury. So again, these programs work. We just need compliance. So the second part of the study, we brought this to the male population in the United States, and we wanted to see, does it specifically decrease the rate of ACL injury in soccer players? And we found, yes, it very much does so. It significantly decreased by total ACL injury rate by 76%, and non-contact ACL, it was 75%. It was not statistical for contact ACLs. So we did see a significant decrease in total ACLs by virtue of utilizing the 11 Plus. We also found that this is related to compliance or adherence. So the more you use the program, compliance is shown in the blue bars, and the time lost due to injury is shown with the red line. And we found that there was a statistical difference between compliance. The more you use the program, the lower the injury rate. And that was statistical between low and moderate compared to high injury groups. The high compliance group was the teams that were utilizing the program more than 2 times per week. So that's a really important recommendation you can make to your patient population. How often do I need to be exposed to these types of neuromuscular training programs in order to impart the benefit? And I would say 2 times. Technically it was 2.1, but if you can get 2 doses per week, I think you can really reap the benefit from a neuromuscular and neuromuscular training perspective. So why is compliance so challenging? I think we have been befuddled by this. We've been studying this for over 20 years. We know these programs work, and not just the 11 plus, not just the PEP program. There are many others out there that have been scientifically vetted, and it's difficult. Translating a prevention program into practice is difficult. So we know when we look at the flowchart of designing injury prevention, looking at the epidemiology and the prevalence, understanding the mechanism of injury, working scientifically to create the intervention, the scaling up and the adoption and the fidelity on the right side of the screen has become our nemesis, our Achilles heel, so to speak. And that's where so many people, Carolyn Finch, Alex Donaldson, so many people have been doing good work in this regard to see how can we ameliorate this particular part of the process, because this, as good as the science is, and as hard as we work as getting super specific on designing these unbelievably valuable programs, if they're not being used, they're not beneficial, are they? So what do injury prevention programs actually do? So what we did, when we designed these programs, we wanted to biomechanically understand how they work, so that way we could regress from a regression perspective and actually make them better. So at the University of Delaware, we looked at the 6 screening tests that was developed by Chris Powers out of the University of Southern California. And we looked at these in both men and women over the course of a competitive season, so in preseason and the postseason. And we wanted to see the changes that were being imparted by virtue of using the 11 plus program. And what we found was pretty interesting. On the negative or sort of no finding sides, we didn't see statistical difference in vertical ground reaction forces, and we didn't see a decrease in injury rate, but the sample size was too small. It wasn't properly, the power analysis wasn't designed to capture injury rate. But the positive findings were we did find improvements to hip flexion and hip flexion moments. We know that is super important from a preventative standpoint in terms of deterring some of the deleterious biomechanics or pathokinematics that we see strategically and significantly with ACL injury mechanisms. We saw decreases in hip internal rotation and an increase in peak knee flexion angle, all positives. The 11 plus has a heavy emphasis on core and trunk, and the biomechanical analysis showed the majority of the delta, the change occurred at the hip. Is that enough? Does the program do enough to initiate the effective kinetic and kinematic change at the knee? So if we're doing enough proximally at the core and the trunk and through the hip, which you know is critical for knee biomechanics, is that enough? So the interpretation, when we look at all of these particular parts of this particular Venn diagram, we want to understand the mechanism of injury, which I think statistically and through the literature, I think that's been done quite well. From a surgical and intervention and rehab intervention perspective, you want to look at graft selection, properly rehabbing, adequately loading and assessing, implementing injury prevention as part of rehabilitation, because that has to be part of their focus going forward. The biomechanical side, looking at 2D and 3D kinematic analysis, it doesn't need to be in a robust biomechanics lab. You can be really strategic with iPhones and iPads and looking at two-dimensional statistics or movement analysis in your own particular clinic. But don't forget the brain. I think, for me personally, I think the cortical control element to the ACL story is the next chapter, or it is our current chapter. If you look at the work of Brian Zarzicki and Dustin Grooms and Meredith Chaput, so many people neurologically working on the cortical control aspect of this, I think this tells an important part of the story. So we know that sensory feedback, when we look at afferent and efferent output and input to the brain after an ACL, is the cortical excitability is significantly increased after an ACL injury. And there's a delay in the corticospinal and the interneuron efferent output, delaying timing and the intensity of contraction after injury. This may persist up to 2 years. And I think that's where the Kate Webster and Tim Hewitt recommendation came out maybe last year, looking at, do we delay return to play for 2 years? Well, is that feasible? I don't know that it is, but I think we have to neurally make assessments and build into our rehabilitation protocols the neurological component to the rehab element, whether that is EMG, intrinsic and extrinsic cueing. There's a lot of important elements here that we need to incorporate into the return to play decision-making process. So the future directions, you want to determine if ACL risk can be detected. This has been controversial as well. Can we even red flag an individual? Can we determine if we see something on a screening, is this predictive? We don't quite know yet, but I think it is still worth doing. We don't throw the baby out with the bathwater, so to speak. We want to determine if our current screening tools have the intended specificity to identify risk, and I think we still have some work to do there. Our testing battery may be incomplete or just not sensitive and specific enough. We want to refine existing injury prevention programs. So what we have done has been out for 20 years. We can do better because we have more data now to go back from a biomechanical perspective and refine those things. Be mindful of neurology. Use EMG, use corticomotor control elements, intrinsic, extrinsic cueing. Spice it up. When I have individuals in the clinic coming back from ACL injury, I give them math problems to do while they're doing balance tests. I ask them to tell me something complex about an English literature essay that we made. I have them doing things that are distractive, doing unanticipated cuts. I use a device to look at cutting that's unanticipated. So be creative and provide equal resources to female athletes. This is improving, but I think there's still some work to do. And we want to improve the compliance to IPPs. As good as we are at developing them, we're only as good as the compliance and adherence is. Thank you so much. It's been such a pleasure. Mm-hmm.
Thank you very much, Ole. We have some questions.
Sure.
I try to take them together because we have some questions about the rehabilitation and some about the prevention. Yes. So I try to take it together. For the rehabilitation, how long do you think it needs to get a good rehabilitation? Mm-hmm. And what are the most important aspects to consider during the rehabilitation?
It's a great question. So earlier on in my career, we were sending back players too early, so around the 6-month mark. And in my estimation, far too short. When I have, unfortunately right now in my clinic, I'm treating a 12 and a 13-year-old that sustained ACL injuries from the same competitive club, very high-level club soccer players. And I'm telling them both, plan on a year. They're still in pubescence. There's so much changing in this particular age group. So I think that's an important variable. How old is the individual? What changes are going to occur over the course that you have them from the rehabilitation perspective? Also, are they collegiate? Are they high school aged athletes, or are they professionals? Are you seeing them twice a week or 5 times per week, 6 times per week? So I would generally prepare people for a year. If we're earlier, then everyone's happy. But I think sort of overstate it, just say we need a year, maybe close to the 10-month mark if we're lucky, 10 to 11-month mark. From a rehab perspective, so we build in strength assessment, biomechanical assessment, EMG. We also do return to sport. We use the return to sport index from a psychological and fear and confidence perspective. That to me is critical. These athletes have to be ready to go back. Despite what we may think in terms of their biomechanical quality or movement, if they have fear and they're not confident in their movement, that is more important than anything that we can assess. So the fear and confidence, whatever return to sport index you want to use, I use 2 in particular, but whatever one you want to use, I think it's important to at least incorporate 1.
Thank you. Mm-hmm. And the other questions are about how many times would you do the 11 plus training, and when make it sense to work with additional weights for you?
Right, a good question. So the 11 plus, when we designed this, it was to be socioeconomically responsible and to not encumber equipment managers. So for example, if we're dealing with communities that are underserved, we didn't want to make it a cumbersome program of, do you need weights? Do you need resistance bands? Do you need all of these? Because I think, one, it affects compliance. If we start saying, oh, you need X, Y, Z to continue to prevent or to utilize the program, people just won't use it. The dosage is 2 times per week at least. If you can get it 3, great, but if you can get it at least 2 times per week, that's ideal, because we've seen statistically it works at 2. But from a weight intervention perspective, so if I have someone in clinic, we start using weights early. But I think that early notion of you can weight train too early, I think that's been disbanded largely. So we start on the ACL side, early on, week 3, we start balance and proprioception and some light resistance work, particularly, the whole debate of open versus closed chain. I think that's been disbanded as well. We can safely do open chain at least at a minimum 90 to 40. So I think absolutely incorporate early, do upper body weight if you're uncomfortable with loading too early, but I don't think there's any real negative in terms of loading too early.
Yeah. Fine. I have on the last question. How about psychological questionnaires? Which do you use or recommend?
So Kate Webster's Return to Sport Index, the RSI, I find that that's quite good. There's another ACL injury profile that I also use. I combine both of those, and I give the RSI to take home, and then from the questionnaire side, I interview the athlete. I think we as physios have a unique relationship with the patient because we know them, unlike the orthopedists that have limited contact with them. And so we really can genuinely interpret the results as an athlete trying to pass the score as opposed to, and you get a sense of like, is this a valid representation of their true feelings? So I think that's also an important conversation. Before you give the test, say, please answer honestly, because this is helping us to help you. And I think that's really important. You're not trying to pass a test because this is one component of many of 6 or 7 variables that we're considering for you to return to train. So please answer these questions honestly, because it helps us help you going forward.
Yeah, thank you. Are you also speaking with the coaches or only?
100%. So, for example, one of these athletes that I had just returned to play, we had an interesting situation where the coach, I had set up a return to training date of, a return to play date of October 30th, and the coach decided to put her back 2 weeks earlier. So I had a good conversation with this particular coach because I'm not dictating a training session, so please don't dictate when this athlete is available for return to play, because there's so much liability associated with that. I mean, it's a dangerous decision to make. But also, interestingly, that athlete wound up having an ankle sprain on the second game back. And that speaks to the psychological preoccupation element, right? Where if there's cortical spinal or cortical excitability still at play here, how do we interpret environmentally everything that we have to without some element of preoccupation to the knee? And I think that we are at risk not only for secondary knee risk, but to other types of injuries where you only have X amount of RAM available to you. How do you interpret the particular environment? So I think it's just a cautionary tale. I'm almost happy this particular girl sprained an ankle because it gave us a little bit more time. And it was an important lesson for the coach and for the player and for the parents that will often push to get back. Yeah. So it's a good conversation to have.
Good. Thank you very much.
Thank you. Thank you for having me.
Thank you. And I give the word to Mario.
And now I would like to pass the word to my friend and president, Nicola.